50-year-old female, a 50-year-old female presented with a recent history of headache. دكتورة تريدين بعد أرجع لك سيكونس؟
لا عشتيتك مالتي بلانر مالتي سيكونس MRI show Pachy meningeal enhancement of the meninges. Also, I see shunt to the lateral ventricle of the right side, decrease in the CSF volume in the ventricle and in the cistern. Also, there is sagging in the mid stem. يعني عندنا also بالsagittal view دكتورة فيني sagittal view اكو venous distension sign هذه هنا واضحة عندنا يعني herniation تقريبا بالcerebral tonsil يعني هذه كلها sign مال يعني intracranial hypotension يعني احتمال لأنه هذا الشنت موجود قلل CSF فصار عندنا ما عندنا other positive sign no mass no أنا ما شفت أكو mass ما شفت any other positive sign otherwise everything normal.
يعني هسه انت حكيتي عن الكومبليكيشن مال الشنط غير لو شنو؟
نعم أستاذ هي هذه يعني الواضح إنه هي كومبليكيشن إنه إحنا من يقل عندنا CSF فوليوم فراح يقل عندنا CSF بريشر فتطلع هذه يعني تصير هاي الكومبليكيشن.
تصير هرنيشن بالسيربيلر تونسل تصير بروميننسي بالفينس ساينسز زين. يعني اللي الكوز اللي ادى انه يخلوا لها شنط شنو عرفناه ولا لا؟
دراسي خلاص هو يعني اللي يخلوه
يعني why they put a shunt يعني
increase يعني هو اي increase بالسي اس اف فوليوم هيدروسيفالس سوينا برجر افكت تقليل البرجر يحطون الشنط واي اكو اسباب congenital او بوست اوب.
وهسه هذا الكوز مال الهيدك مالتها
طبعا هو يسوي postural headache.
postural headache. فإذا in conclusion هذا الدايجنوسيس شنو؟
هذا النوع الإياتروجينيك intracranial hypotension. يعني
مثلا
احنا عندنا
في
نوعين، برايمري وسكندري. البرايمري هو سبونتينيوس، يعني مرات يصير مثلا فيستولا للفينوس، او يعني هو يقلل السي اس اف، او للجورا يصير بيها تير without iatrogenic. بس هذا iatrogenic عندنا احنا كوز قدامنا واضح.
وما عرفنا انه ليش خلوا الشانت يعني.
نسأل
يعني انت
الدكتورة هم ليش خلوا الشنط؟
أي نعم نعم موجود. الهيستوري هي كان عندها يعني أركنويد سيست انترافنتريكولار، وحطوا لها شنت، وهذا كان يعني البرزنتيشن ورا الشنت يعني بليسمنت اجتي. نعم.
اذا there is يعني كان اكو انترافنتريكولار
أركنويد سيست.
اركنويد اللي هو شو اسمه زين اركنويد انترافنتريكولار اركنويد يخلوا له
والله اي استاذ،
شنط.
اي هم كان يعني هو مطين السجستشن، يعني شفت البريفيوس ام ار اي كانوا كاتبين انه اكو شن يعني انترافنتريكولار سيست، وبعدين هم حطوا لها شنت. ويعني اجتي يعني هي ورا يعني فترة قليلة كانت تعاني يعني هدك، وسوينا لها الام ار اي وكان هاي الفايندينجز.
عندك البريفيوس ام ار اي
عندي
صورة.
استاذ صورته نعم، بس ما نقلت
خليه
يعني.
يشوف.
لا ما عندي، بس صورة التقرير استاذ، مو ال يعني الفحص لا.
والسايز مالته سمول لارج كان انترا فنتريكولار
أه
اركنويد.
والله أستاذ هذا عندي إياه، يعني هم كاتبين قياسه 28 في 57 في 31. اي نعم أستاذ، يعني هم مطين هذا السجستشن اريكنويسيس أو نيورو انتركسس انترافنتريكولار. اي نعم.
وهذا الشنط كاثيتر خلوه بالسيست لو بالفنتريكل.
بالفنتريكل أستاذ هسه هنا.
والسيست وين راح؟
يعني أستاذ أنا ما يعني هذا أنا أخذت البريفيوس ام ار اي، وهذا هو الريسنت ام ار اي يعني
لو ماخذه يعني لو ماخذه الاماره كان شفناه.
ما يعني هي ما جايبته، كانت جايبة بس التقارير، وبعد هي راحت حتى يعني ما شفت انه كفولو اب وراها ما.
فاذا هذا يعني خلينا نقول انتراكرينيال هايبوتيشن دي مثل ما قالت دكتوره رشا انه iatrogenic secondary to the VP shot.
نعم أستاذ.
احكي لنا على الكيس وده مسوي توك تفضل.
اي نعم أستاذ، مثل ما قلت هي البيشنت يعني كان عندها intraventricular cyst، انه الشنت was يعني placed، واحنا نشوف هنا اول شيء عندنا ال posterior horn of the lateral ventricle انه slit like. نشوف بالساجيتال فيو عندنا distension of the dural venous sinuses، وهي هاي تعطينا يسموها ال venous distension sign. هنا عندنا الساينز مال البرين ستيم ساجينج، اللي احنا هنا نشوف انه الاماميلو بونتاين ديستانس هي decreased. نشوف البري بونتاين ديستانس decrease، واكو عندنا mild amyotonsillar herniation. and in the post contrast images نشوف عندنا diffuse smooth pachymeningeal enhancement. فطبعا يعني in combination with the patient symptom with the imaging findings, a diagnosis of secondary intracranial hypotension was made. Um, فاليوم my talk will be about intracranial hypotension. So in order to understand the imaging finding, we should know about the pathophysiology. The imaging findings can be broadly divided into the brain sagging and the reactive changes. Regarding the brain sagging, احنا normally the brain هو surrounded by the meninges, and the meninges they are act like a bag filled with fluid, which is the CSF. And the CSF will provide cushioning or support to the brain. فإحنا البرين هو normally weighs around 1.5 kg, but with this support the apparent weight will be about 50 grams. So this CSF will make the brain float. So in case of the CSF leakage, the brain will descend down, and this descent will also cause sagging of the meninges, and the meninges they has sensory nerves and the veins, and this will lead to the patient suffering from the headache. And obviously, this headache intensity will increase when the patient stand up because there will be greater traction, and that's why the patient will suffer from postural headache. The other findings, which are the reactive findings that we saw, they can be explained by the Monro and Kelly hypothesis. So in the equilibrium state, inside the skull, we have three components: the brain tissue, the CSF, and the blood. And each one has a fixed volume. But if we have decrease in the volume of one component, there should be compensation by the other. So in case of intracranial hypotension, the decrease in the CSF, it will be compensated by increase in the blood volume. And this is because of the signs, the pachymeningeal enhancement, the venous distension sign, and the subdural fluid collection. So intracranial hypotension can be broadly divided into the primary, which is called the spontaneous, and the secondary. Like our case, it could be iatrogenic in case of lumbar puncture surgery, overshunting due to divergent device, or traumatic. This spontaneous intracranial hypotension caused by CSF leakage that almost without exception occur from the spine, either into the epidural space or directly into the veins, either through a dural defect, a CSF venous fistula, or a ruptured nerve root. This is a diagrammatic illustration to better explain the causes. So here, the image A, we have an anterior osteophyte causing an anterior dural tear that caused the CSF leak. On the image B, we have a leaking nerve root diverticulum. And the image C, we have a CSF venous fistula. The criteria for the diagnosis: first, having a low CSF pressure lower than 6 cm water, or signs of intracranial hypotension on imaging. Second is the orthostatic headache. And third, no iatrogenic cause and no alternative cause for the headache. The role of imaging first is to diagnose the intracranial hypotension, finding the site of the spinal CSF leak, and also image-guided treatment. But we should keep in mind that in 10% of patients with spontaneous intracranial hypotension, there will be no imaging abnormalities, so a normal MRI does not exclude the diagnosis. Of course, MRI is the modality of choice for the diagnosis, and the imaging findings in order of frequency from the most frequent one, which is the dural thickening and enhancement, and this is seen in... Hello?
تفضلي.
عبالي الصوت.
لا
The
لا
most the most frequent one is the dural thickening and enhancement, and this is seen in 83% of patients. So this is an example. This is the axial flare and T1 post contrast. We see the diffuse, smooth pachymeningeal enhancement. The second imaging find is the venous distension sign, and like we said, this is one of the reactive changes due to the volume depletion. The venous sinuses will dilate and engorge, and this is seen in 75% of the patient. So this is the normal. This is the normal transverse sinus, and here is the patient with intracranial hypotension. It will have a convex border, and this is called the venous distension sign. The third sign is the brainstem sagging, and this is due to the downward placement of the brain. So this is the normal. We see the midbrain, and here is in patient with intracranial hypotension, we see the midbrain is compressed. And this is better seen with the sagittal images, and these lead us to other sign called the quantitative signs. And this is, we saw it in our case. So due to the brain stem sagging, there will be decrease in the, in the mammario-pontine distance to lower than 6.5 millimeter. Other quantitative sign is the decrease in the pontomesencephalic angle. This is the normal, and this is decreased to lower than 50 in a patient with intracranial hypotension. Other signs is the effacement of the suprasellar cistern, as you can see here, to 4 millimeter or less. Other is the prepontine, also cistern effacement. So this is an example. We see how the ventral pons is flattened, and also there is decrease in the prepontine cistern distance. Other important findings is the tonsillar herniation. This is very important because it may be misdiagnosed as Chiari 1 malformation, and actually this sign is called the pseudo-Chiari in intracranial hypotension. So the correct clinical setting and the finding of other signs is very important. So we see this patient has a diffuse pachymeningeal enhancement. On his sagittal image, we see there is tonsillar herniation, there is a flattening and decrease in the prepontine distance. And also we see other sign, which is enlargement of the pituitary gland, and this is due to reactive hyperemia. And this is also very important because it may be misdiagnosed as a pituitary tumor. And here is the cause. On the MRI, we see that there is CSF extravasation, and the cause was an osteophyte at this level. Other sign is the decrease in the fluid within the optic nerve sheath. And this is an example. This is the pre-op and the post-op. This patient has a CSF venous fistula. And we see in the pre-op image, there is almost no fluid around the optic nerve sheath. But after the ligation of the fistula, we see the restoration of the pre-optic subarachnoid space fluid. Another finding is the subdural collection. So if the pachymeningeal venous dilatation was not enough to compensate for the volume depletion, the fluid will continue to extravasate, causing this fluid collection. So this patient has a diffuse pachymeningeal enhancement, and he has bilateral subdural collection. And here's the cause. The patient had multiple prominent meningeal diverticuli. The spinal changes could be in form of spinal subdural or epidural fluid collection, distended venous sinuses, and abnormal enhancement, as we can see here in the T2 FATSAT and the post-contrast images, the venous epidural dilatation and abnormal enhancement. But we should keep in mind the spinal changes may mimic epidural inflammation. So the correct clinical setting is very important to not miss the diagnosis. We have what's called the Bern criteria. This is a scoring system based on the MRI findings and help to predict the probability of the CSF leak in patients with spontaneous intracranial hypotension. So we have 4 major criteria and 4 minor criteria. The major criteria are engorgement of venous sinuses, the pachymeningeal enhancement, and the supracillar cistern effacement, and each one will take 2 points. While the minor criteria, the subdural fluid collection, the prepontine cistern, and the mammapontine distance, each one take 1. And the interpretation, if the score was from between 0 and 1, then we will have a low probability. If it is between 2 and 4, we have intermediate. And if it's between 5 and 9, then we'll have a high probability for the diagnosis. So in conclusion, MRI is the modality of choice for the diagnosis. Understanding the Monro and Kelly hypothesis can help explain many imaging signs. And the diagnosis of spontaneous intracranial hypotension should promote additional workup for detecting the cause and location of the underlying CSF leak. The use of structured reporting template based on the Bern score can help improve detection and decrease the false negative in brain MRI performed for a spontaneous intracranial hypotension. And thank you.
شكرا